Young Physicians, Young Internist Hub of Sri Lanka College of Internal Medicine, the Next Gen Forum. We have initiated this forum to share the specialist insights and knowledge from the next generation in the field of medicine in Sri Lanka. We will have young experts in the field of medicine sharing the experience related to internal medicine through this next gen forum. So today we are going to have our first webinar of this series. First of all, let me cordially invite Dr. Madhuvanti Hettiarachchi, the President-elect of Sri Lanka College of Internal Medicine, to deliver the introductory speech and welcome the gathering. Over to you, madam.
Good afternoon, everyone, and thank you, Sahan, for those kind words of introduction. And today marks the inaugural webinar organized by Young Internist Hub. As the name implies, actually the Young Internist Hub consists of all the young internists who are in their early years of their career, and they are the future of the Sri Lanka College of Internal Medicine. And they have always helped us, the college, to in various capacities. And this year, under the guidance of Dr. Krishanta Jayasekara, the President, Sri Lanka College of Internal Medicine, and we have formulated this Young Internist Hub with the prime aim of getting the young internists to interact more with the college in our various activities, the projects, the audits, researchers, as well as be part of the expert committees and guideline development committees, so forth. And I should be thankful to Sahan, Dr. Sahan Mendis, our Secretary, Sri Lanka College of Internal Medicine, for being very passionate about this whole project and being taking the lead. And without further ado, let me warmly welcome Dr. Sithira Seneviratna, consultant geriatrician attached to National Hospital Colombo, who has kindly agreed to deliver the first talk of this Young Internist Hub and the webinar series organized by the Young Internist Hub. And let me invite Dr. Sahan Mendis to formally introduce our speaker and carry on. Over to you, Sahan.
Thank you, madam. So let me introduce the speaker of the day, Dr. Sithira Akalanka Seneviratna, MBBS Colombo, MD Geriatric Medicine Colombo, MRCP UK, MRCP Geriatrics Medicine. Dr. Seneviratna graduated from the Faculty of Medicine, University of Colombo in February 2014. He completed his MD in Geriatric Medicine in 2020 and obtained MRCP UK in 2020, completed Specialty Certificate in Geriatric Medicine with RCP in 2024. He was a former Senior Clinical Fellow in Geriatric Medicine and Perioperative Medicine in Oxford University Hospitals from 2022 to 2024. Currently, he works as a consultant geriatrician at National Hospital of Sri Lanka. He is one of the first board-certified consultant geriatricians in Sri Lanka, and he is the only board-certified consultant geriatrician of the country at present. So we are honored to have Dr. Seneviratna here today with us. He currently holds the post of Secretary, Fragility Fracture Network of Sri Lanka, and he's also a council member of Sri Lanka Association of Geriatric Medicine. Since 2021, he is a member of British Geriatric Society and a member of International Parkinson and Movement Disorder Society. Dr. Seneviratna's special interests are on orthogeriatric care and geriatric palliative and end-of-life care. And he has done several researches on geriatrics, orthogeriatrics, and falls in older adults. Dr. Seneviratna will talk to us on orthogeriatric and perioperative medical care in older adults today. Before starting, I must also inform our participants that if you have questions, you can put them on the Q&A section. So Dr. Sithira will take the questions for discussion at the end of the lecture. So without further ado, I cordially invite Dr. Sithira Seneviratna to deliver his lecture. Over to you, Dr. Sithira.
Thank you very much for that kind introduction. So I'm sharing my slides now. Hope you can see the slides on screen.
Yes, we can see.
Yeah, thank you. So today I'm going to talk about orthogeriatric and perioperative medical care of older people. So orthogeriatric is kind of a new subject in our setting. So I'm going to give you an overview and to give some details about what we do in orthogeriatric and perioperative care in the adults. So the reason why we are discussing geriatrics is this. So we have a aging population. So I am sure you might have heard in different forums that Sri Lanka has the fastest aging population in South Asia. And if you look at the data, now we are here in 2000, between 2020 2030, and our population is going to be rising forever, until 2100. If you can see, we are reaching about 45% of our total population being more than 60 years. Even now, we are reaching about 21% of our total population possibly being more than 60 years. That's the prediction at the end of this year. So, geriatrics, knowledge on geriatric care has to be uh, familiarized not only among geriatricians but also general specialists as well. So, when you talk about perioperative medicine, it's a multidisciplinary subspecialty that involves collaboration of many specialists and especially delivering uh, care for older adults undergoing various types of surgeries. So, how did this start? So, this started as orthogeriatric care and then it evolved into perioperative care. And orthogeriatric care means giving multidisciplinary care led by a geriatrician to patients who have fragility fractures, right? So orthogeriatricians were the first perioperative physicians initially, and then now it's actually gone to other types of surgeries as well. So if you talk about the early days, he's the pioneer of orthogeriatrics. His name is Lionel Cousin. By profession, he was an orthopedic surgeon and he was also named as a geriatrician. So he has his initial training in orthopedic surgery and was posted in 1930s to uh, institute where there were chronically sick patients who were considered as incurable. All right, and those days, because of the World War II, his career came into a hold. So what he did was he developed a special interest in these incurable patients and try to rehabilitate them. So one of these diseases was hip fracture. So those days, if you have an older patient with hip fracture, it is considered as not uh, it is incurable, not able to cure. And the lion cousin operated on these patients and rehabilitated them. And then he saw these patients are showing signs of improvement. So that's how orthogeriatric care started. And later on, he developed a career in geriatrics as well. So he was one of the uh, leads in geriatric care in 1950s. When it comes to orthogeriatric care, the hip fractures are known to have most of the complications and carry highest risk of mortality. So people develop their initial interest in providing care for patients who have hip fractures. So, and then now this interest has gone beyond hip fractures to patients who have femur fractures. And now there's a separate branch of orthogeriatrics named spinal orthogeriatrics. And now in some settings, they have moved to care for patients who have upper limb fractures as well as elective orthopedic surgeries. When it comes to perioperative medicine, so it goes beyond orthogeriatrics. So we provide care for patients with geriatric trauma and the elderly patients undergoing general surgeries, especially major abdominal surgeries, vascular surgeries, and other types of major surgeries. So when talking about perioperative care, so we have three phases. We are talking about preoperative phase, intraoperative phase, and postoperative phase. And so why do we need a physician or a geriatrician in a surgical team, and how can they improve the outcome? So that's what we are going to discuss today. So if you look at the predictors of surgical outcomes, it's not only the nature of the surgery or the surgical technique, or for the person who is performing the surgery, which determines the outcome. But there are a lot of other contributory factors. For example, especially in these older patients, aging and their reserves, the medical comorbidities, their social support, and the presence of geriatric giants such as malnutrition, frailty, cognitive problems also affect the surgical outcome. So that's why we need to have someone who is familiar with handling geriatric problems and optimizing their medical comorbidities and optimizing their reserves in this period. So that's why we need a physician or a geriatrician, the perioperative team. And so one important thing when you talk about the patient's reserves is frailty. So I'm sure you have heard about frailty in different forums. So by definition, frailty is decreased physiological reserve and resilience. All right. And so this, if you are frail, this makes you more vulnerable to stresses and lead to functional decline. And this is in this graph, it will be more clear to you to understand this concept. So this the first green line is a trajectory of a fit person, and this is the functional capacity in the y-axis and time in the x-axis. All right. So when he develop acute illness, what happens in a fit older person? Their functional level goes down, but soon they recover and they go back to their baseline. All right. But if you consider a real older person with even with a minor illness, their functional level goes down drastically and could go down below the independence range to the dependent range. And it takes a longer time to recover than a fit older person. And often actually, they end up in a functional state lower than where they were. All right. So this is the expected trajectories of a fit and a frail older person. Right. And when you look at the data on frailty and surgical outcomes, it's proven in many settings that frailty is an independent predictor of surgical outcomes. So there are a lot of meta-analysis done, and it has been shown in various major surgeries. If you are frail, you have higher risk of being uh, developing complications, having higher risk of mortality, higher risk of becoming dependent post-operatively. Right. So these are some evidence from some studies. All right. So this graph is a similar graph for a person who is undergoing surgery. So surgery is again, it's like acute illness. It's also a stressor, right? So a person who is having getting a stressor or a surgical stress. So like I explained earlier, the functional level goes down, but they recover quite fast if they are healthy. But if it is an older person who is having poor reserves, or in other words, who is frail, what happens is their functional level goes down to a dependent level, and they sometimes they don't come back to their normal level, and they develop a lot of complication in the meantime. Right. So what we do as perioperative team is we try to intervene preoperatively, intraoperatively, and postoperatively to change this trajectory. Right. So preoperatively we can do risk assessments, and we discuss something about rehabilitation. So like rehabilitation, before they get the surgery, we do them rehabilitate and increase their reserves. And during the perioperative period, intraoperative period, we do certain things to prevent adverse outcomes. And postoperative, we rehabilitate them well and make sure they reach their previous independent level. So we'll discuss details of this as we go along the presentation. All right. So these are some pathways, frailty pathways designed for patients who are undergoing emergency as well as elective surgeries. And so I talked to you about the risk assessment. So not to forget about these risk prediction scores, which we use quite often in perioperative clinics. And this is such a calculator, NSQIP calculator. And if you do the calculation preoperative for these frail old adults, so this is how it will look like. It will give you some percentages of certain complications that can arise post-operative. So we can discuss the risks with the patient and also the families, as well as we can take certain measures to avoid these complications post-operative. So there are some other risk scores like Peri score, POSUM score, and SWOT score, which are quite useful. All right. So now we are changing our direction to orthogeriatric care. All right. So uh, I discussed how the orthogeriatric care started about in 1940s, and now it has gone a long way. And so we have in most of the country, developed countries worldwide. So the standard orthogeriatric care is the care given to these patients with fragility fractures, come together with surgeons as well as geriatricians. All right. So when you talk about fragility fractures, we have to also talk about falls. All right. So falls lead to fragility fractures. That's how people get fractures. So one third of all adults more than 65 years, they will fall at some point. All right. And it increases when you are more than 80 years, half of the people will fall. All right. And the problem with falls is when you have a fall, you are prone to have another fall. So we call them recurrent fallers. And ultimately, these falls result in fractures. So there's a connection between frailty, falls, osteoporosis, and fractures. All right. So these are interconnected. And when you see a patient with a hip fracture, it's not only the fracture. You have to think this happened because patient was frail and because patient had a fall. And of course, patient had underlying osteoporosis. Right. So this is we call osteoporotic journey. So when we are in 50s, between 50 to 60, we tend to get police fractures. Then people tend to develop multiple vertebral fractures over time, and ultimately they get a hip fracture. All right. So incidence is quite remarkably high worldwide. And if you look at the Sri Lankan data, so this study was done in National Hospital last year. Within 1 month, there were about 220 patients who had fractures admitted to accident service. And out of these 222, 94% were due to these only female patients. 94% were due to falls. Only 4% was due to RTA. So the predominantly the geriatric trauma patients are admitting because of the falls. All right. So if you look at the outcomes of these hip fractures, even in developed countries, about 20 to 25% of patients will die within 1 year of a hip fracture. So in our setting, the mortality is even higher. And not only the mortality, most of these patients will be dependent even after several years of the hip fracture. If you look at some studies done in Sri Lanka, so you can see this study was conducted in Sri Lanka, and you can see 99% and 81% and 75% respectively were remain dependent after 1 month, 3 months, and 1 year following the surgery. All right. So even after 1 year of hip fracture surgery, 75% were still dependent. So as you can see, it carries a huge risk, huge burden on the carers. All right. Okay, so now older people they do fall, and falls ultimately result in fractures, and these fractures have very bad outcomes. How can we improve these outcomes? Can geriatricians or physicians help in improving these outcomes? So again, going to these geriatrics, as I discussed before, this started in 1940s, and in 1960s, Michael Davis he was a orthopedic surgeon, and Robert Irwin is a geriatrician, and both of them thought we should have a work together and did a combined orthogeriatrics. In 2006, the famous Blue Book for the South, and 2010, the best tariff of hip service has gone beyond the neck of femur to the involve the complete femur. All right, so this is how orthogeriatric service has expanded in United Kingdom over for last 80 years. All right. So these are the best tariff requirements at the moment to a hospital should achieve to get certain funds to maintain the service. So time to theater less than 36 hours, and involvement of an orthogeriatrician in the following, achieving these following goals. So we'll discuss these things as we go. Right. Discussing about orthogeriatric models of care. Patient get a hip fracture. Where should this patient get admitted, and how should the geriatrician or physician uh, involved in patient's care? So, model patient would admitted under the orthopedics to geriatrician or the physician, right? And when it comes to geriatric consultation model, so orthopedic surgeons in different units will refer the neck fracture patients to geriatrician. Now, going little forward from geriatric consultation model, the orthogeriatric co-management model is a geriatrician is appointed the orthopedic board and they are doing a co-management, and orthopedic surgeon is getting the leadership. Now it has gone beyond that, where the geriatrician sometimes get the lead, especially post-operatively, and patient is admitting under the geriatrician, and orthopedic surgeon is doing the surgery. And in the geriatric-led model, geriatrician is also involved in the pre-hospital community care. All right. When it comes to the orthogeriatric care, we discuss about the four pillars of orthogeriatric care, which are multidisciplinary acute care, rehabilitation, secondary prevention, and national alliances. Okay. So regarding acute care, so the first thing is diagnosis. Okay. Now, when a patient present to ED following a hip fracture, so the standard is to diagnose a hip fracture clinically first, and then if you're suspecting clinically a hip fracture, to get a X-ray to confirm it, right? And but there are certain, percentage of fractures which will go missed in plain radiograph. So we need to consider either CT or MRI. Okay, so out of CT and MRI is considered as the gold standard of detecting the hip fracture. So CT can 100% exclude a hip fracture. Very important point. And but in low resource setting, we can go ahead with the CT. All right. If patient continues to have pain in the hip area. Uh, I mean, if the X-ray or CT doesn't show anything, that does not exclude hip fracture. Still, you have to go ahead with the MRI to diagnose occult hip fracture. Right? And at presentation, we need to do a focused, comprehensive geriatric assessment to get an understanding about this patient's medical problems before we are pushing the patient to the theater. So during this comprehensive geriatric assessment, the geriatrician will assess patient's medical conditions, patient's cognition, patient's pain, nutrition status, frailty, and other areas as well. And things like mechanism of injury, false history, alcohol smoking, and patient's social background, their advanced decision-making capacity. This is also very important. So this is one of the uh, assessment forms I used to do. Okay. Acute problems, medical history, functional status, their cognitive function, frailty, and their medication, alcohol smoking, false nutrition status, renal functions, social support decision making capacity, and advanced care. Do they have any advanced care plan? So everything is important actually before we put the patient to the theater bed, because things can go wrong perioperative. This and we have to have a thorough understanding about patients' geriatric problems before we do the surgery. So this assessment uh, is a quick, focused, comprehensive geriatric assessment, which takes around 15 to 20 minutes. Right, pain. So pain is very important uh, when you talk about acute care. And in one of the studies I did, it showed pain is the strongest predictor of postoperative delirium. Right. So an assessment of pain can be quite tricky during this period, especially because of these patients. Most of these patients have perioperative delirium, and some significant amount of patients are having pre-existing cognitive impairment. So they might not be able to express pain. And so you need to use certain uh, cues, non-verbal cues to detect pain in these patients. And we, as a standard, we start everyone on regular paracetamol, unless they are allergic to paracetamol. And then fascia block is a very effective way of relieving pain, especially in ED, and also can be repeated in the wards, and which has very less systemic side effects compared to other analgesics. And the second option is usually going for opioids because NSAIDs have shown to have a lot of adverse events during this period. Especially, it can cause renal impairment perioperatively because patient is in kind of a fluid depleted status, and it can cause GI problems, and it has also been shown that NSAIDs delay fracture healing. So, as a stand, we avoid NSAIDs, a patient who is having pain due to hip fracture. The timing of the surgery, the aim is to do the surgery as soon as possible, and especially we try to do the surgery within 36 hours. The previous standard is 48 hours, but there are studies which has been shown if you delay the surgery, the outcomes will be much worse. All right, there's this interesting study about doing a hip fracture surgery within 6 hours, a hip attack, which is published in Lancet, and it shows that if you do the surgery within 6 hours, quite soon, the rate of delirium will be significantly lower. But there were no changes in mortality because it's a huge thing to get the surgery done within 6 hours. At the moment, it's not being practiced in many centers. The current standard is to get the surgery done within 36 hours of admission. Right. So this is about how we are adhering to, these standards. So this study was done in South and Southeast Asia about service availability and readiness for infrastructure care. And if you go through this data, you can see, so these are countries in our region, Malaysia, Nepal, Philippines, Sri Lanka, and Thailand. If you look at the data, the patients in this study came to the hospital within 4 hours of fracture, quite standard. And they were moved to the orthopedic ward within zero point 0.9 hours, which is quite fast, but they get the surgery after 8 days of admission. So you can see if you compare the timing of the surgery in the region, time to surgery. So Sri Lanka carries the highest duration of admission to surgery timing, 8 days, and they were discharged quite fast. So we can see we are not spending that much of time on rehabilitation after the surgery. All right. Okay. And this is one of the studies I did a couple of years ago in Kalubowil Hospital. So these are the data in uh, the previous study. So this was done during the COVID period. So patients came to the hospital quite late compared to standard 4.2 hours, which was seen in the previous study. In our population came 75.6 hours after the hip fracture, but they had again 4.6 had to spend 4.6 days in the hospital before they get the surgery done. All right. So remember the current standard, we are trying to get surgery done in 36 hours, and we have a lot of work to do here. Right. Medication management preoperative is quite important. So what medications we have to stop, what medications we can continue. All right. So especially in regard to the antihypertensives, when a patient get hip fracture, you get lot of bleeding, all right? Especially if you get subtrochanteric fracture or a mid-shaft fracture, there will be significant amount of bleeding. So with the patient is in a fluid depleted status, all right? So drugs like diuretics and AC inhibitors can cause renal impairment, right? And especially during the intro period, when you give uh, uh, anesthesia, the blood pressure drops. And when this happens, again, there are risk of getting renal impairment. So we, as a standard, we stop AC inhibitors and diuretics preoperatively. All right. And beta blocker is a type of medication which has shown to prevent postoperative myocardial infarction. So we tend to continue beta blockers perioperative. But if you start a beta blocker newly to a patient who is having high risk of myocardial infarction, it does not prevent myocardial infarction. But if he is already on beta blockers, we tend to continue beta blockers. And anticoagulants, we need to stop before the surgery. And if they have high risk of developing a clot, we need to bridge it with heparin. And antiplatelets, we can continue basically. And hypoglycemics, we need to especially be careful about SGLT2 inhibitors because it's a high stress situation. We have to stop it, and we can start insulin as required. And certain medications like Parkinson medications, we have to continue. So these are some of the flow charts I used about dabigatran. Likewise, we need to have our unit policies about how to handle anticoagulants during this perioperative period. All right. These are some recommendations about how to do the surgery if patient is on these type of anticoagulations or antiplatelets. So currently, the recommendation is anyway we can do certain things and get the surgery done within 36 hours to make sure patient get a better rehabilitation outcome. All right. So whatever the anticoagulation antiplatelet patient is on, we can prepare the patient to get the surgery within 36 hours. All right. So in regard to the intraop care, so anesthetists play a major role in the intraop care, right? So especially adequate pain control during the surgery and managing intraop, preventing of hypertension, hypothermia, and bleeding is quite important. So there are certain complications that can arise during the surgery, like myocardial infarction, pulmonary embolism, fat embolism, and cement embolism when you inject cement to the prosthesis, right? And mode of anesthesia is usually determined by the anesthetist. So the current recommendation is as the anesthetic, according to the anesthetist preference, you can decide on whether you give GA spinal anesthesia, right? Post-operatively, geriatrician has to play a major role, especially managing the post-op medical complications if they arise, like chest infections, acute delirium, pulmonary embolism, myocardial infarction are quite common complications post-operatively. So the physician has to be very vigilant about these complications. And pain management is very, very important. And delirium is about 50% post-operative in this patient. So delirium management is quite important. And bladder bowel care, prevention of pressure ulcers, and prevention of pulmonary complications is very important. And DVT prophylaxis is something which sometimes uh, we get missed actually. So current recommendation is to continue DVT prophylaxis 4 weeks after the surgery. So patient has to be discharged on DVT prophylaxis up to 4 weeks. All right. Okay, that's we discussed about acute care, and now we are going to discuss about rehabilitation. All right. So as you see in the previous studies, we do the surgery after 8 days, and data says like our average, duration of discharge is about 8.2 days. So the patients spend less time in the ward before they go home. So most of the patients, when they go home, they might spend most of the day in bed, and gradually they decline and they develop certain other complications while they are at home. So our task should be to do the surgery as early as possible, preferably within 36 hours, and do some rehabilitation before they go home. So this rehabilitation process has to be led by a physician or a geriatrician, and has to have the multidisciplinary team uh, get involved in the care, so especially the physiotherapists. So the aim is to mobilize these patients on day one after surgery. So unless contraindicated, by unless the surgeon or the patient develop any medical complications like myocardial infarction, if they develop, if the surgeon uh, says that there's some, difficult surgery where there has been some cortical breach when they insert the nail, if there are some contraindication, we can postpone. Otherwise, the current standard is everyone else otherwise has to be mobilized on day one after the surgery. Okay, right. So, what is the geriatrician's role during this period? Multidisciplinary teamwork, coordination of the multidisciplinary teamwork, and setting up rehab goals, proper pain management again, supporting delirium recovery, nutrition support, medication management, and managing post-op medical complications. All right. So some of these patients, might need intermediate or transitional care before they go home. This is something again we don't have in our system, which we need to focus on in the future. So once they are discharged from the acute hospital, can spend some time in intermediate care hospital closer to their home before they get the independence. Right. Pillar three is secondary prevention. So I discussed previously. Now, this when you see a patient with hip fracture, it's not only the hip fracture you are seeing. It's the interplay between frailty, osteoporosis, falls, and a fracture. All right. So we need to do falls prevention if you need to prevent a fracture. Right. And most of these falls, if you assess, are not due to a trip or a slip, or they are not accidental falls. All right. So they are multifactorial geriatric falls. More than 90% of these faults are multifactorial. That's why we need to do a comprehensive geriatric assessment and to find multiple contributory factors. For example, these patients might be having some cognitive impairment, having some visual impairment, some problems with their balance. Maybe they are developing postural hypertension and on multiple antihypertensives, and they have sarcopenia, and they have they have peripheral neuropathy. So multiple factors might be contributing to their false risk. So we need to do a focused comprehensive geriatric assessment and then optimize these risk factors and take certain steps or multi-level interventions to prevent a second fall. And in regard to the osteoporosis, the hip fracture is osteoporotic process defining fracture. You don't have to do a DEXA scan to diagnose osteoporosis if you have a hip fracture. So the current standard is try to treat these patients with IV sulfuric acid before they are discharged from the hospital. Otherwise, we miss these patients. All right, we have to have a unique protocol on how to treat these patients, uh, how to treat osteoporosis in these patients before they are discharged. Right. So and remember, the first fracture heralds the second fracture. And if you look at the data, the first 2 years after the hip fracture is a imminent fracture risk period. So a person could develop a second hip fracture within first 2 years of a first fracture. As you can see, uh, quarter of patients develop actually another hip fracture during the first 2 years. All right. So when you talk about osteoporosis, we define osteoporosis by the bone mineral density. So we usually get a bone DEXA scan done. It is less than 2 minus 2.5. We categorize them as having osteoporosis, and then we treat them. But if you look at the data, most of the fractures happen in these patients who are having osteopenia rather than osteoporosis. So if you have osteoporosis, the fracture rate will be higher, but if you look at the fracture number, most of the fractures are happening in patients with osteopenia. So if you have osteopenia and high falls risk or high fracts, so we need to think of preemptively treating them with medications to prevent a hip fractures. All right. Okay. Now, in regard to giving sulfonic acid while in patients, there are certain challenges. So we have to have our unit protocols again. So the two common problems are if your creatinine clearance is less than 35, and if you have low vitamin D level, low hypocalcemia, low calcium, we might not be able to give sulfuric acid. So in which case we have to replace calcium and vitamin D, and then go ahead with sulfuric acid. So other problem is now uh, the other thing is now the current recommendation to be sulfuric acid 5 milligram is quite expensive, and which is not also available in the hospital formulary. And but there are certain studies done in especially low resource settings where they compare 4 milligram versus 5 milligram, and 4 milligram has been shown to be very effective in preventing a hip fracture. The 5 milligram is slightly better than 4 milligram, but 4 milligram is quite effective. So at the moment, what we are practicing is we are going ahead with 4 milligram of sulfuric acid. When you talk about vitamin D deficiency is quite prevalent, and doing a vitamin D level will be very, very costly. So, if you are, suspecting vitamin D deficiency, if a patient is homebound, very frail patient with low BMI, so high chance the patient might be having vitamin D. So, even without checking vitamin D level, we used to load these patients with the vitamin D and try to give sulfuric acid before they discharge. All right, and usual, standard is to give vitamin D loading dose weekly, but there are certain studies again done, and so for the because otherwise the patient might need to be in the hospital for a long time. We tend to give vitamin D loading dose daily and load about 300,000 and try to give sulfuric acid before they are discharged. We call it rapid loading. All right, and anabolic therapy is the new trend now. So romosozumab is the new agent in osteoporosis management. So it has been shown clearly if you give anabolic therapy before starting anti-resorptive therapy, it gives you more benefit in preventing osteoporotic fracture. So and now current trend is to go ahead with uh, romosozumab, but we don't have it in our setting. And going for the pillar four, the policy changes is also very important. And we have the global fragile fracture network which is geared on improving hip fracture care globally. We also have Fragile Fracture Network Sri Lanka, which we are trying to develop these policies in our setting. Right. So having a national hip fracture database is quite important. This is how the UK National Hip Fracture Database has improved over years, and now all the hospitals in NHS they feed the National Hip Fracture Database. So we need to start National Hip Fracture Database for our setting as well. And these are some key performance indicators which also geriatric teams are trying to get adhered. Right. Okay. So these are some effective pathways, and we are at the moment collaborating with orthopedic surgeons and trying to develop effective path for Sri Lanka. All right. Okay, that's about orthogeriatric. So the orthogeriatric was the beginning of the perioperative medicine on older people, but now it has gone beyond orthogeriatric care. And when you talk about perioperative care, one of the most important areas is pediatric trauma. All right. So I will give you a discuss case scenario just to get an idea about how these trauma patients look like. Right. So this is about 85-year-old female with advanced dementia and hypertension, COPD, presented with a fall at home. And she felt giddy while standing from sitting and fell on her right side. And the clinical failure score was 7. She has sustained right humerus fracture, right side rib fractures from 2 to 10, and liver laceration and mild chemothorax. And we calculate this score called injury severity score, which is 42. I will go into details of ISS in a while. Okay? Right. So as you can see, now this is the common scenario for older people. So I think you can remember earlier I showed you a study done in National Hospital, and within a month, there were about 900 admissions to the accident service. Out of those 900, about 45% were geriatric patients. And out of these 45% who are like more than 60, 222 had falls, and 95% were due to falls. All right, 222 fractures, and 95% were due to falls. So falls is the leading cause of a fracture. All right, now you can see this patient just by a simple fall at home, she had sustained multiple fractures, humerus fractures, right side rib fractures, and had a liver laceration and a hemothorax. So the injuries they can sustain even with a mild fall, falling from standing height could be very significant. So that's why now these patients are quite complicated. That's why a geriatrician again is needed to look after these patients in the perioperative period because these patients carry high risk of mortality. Right. So in regard to injury severity score, so in this case scenario, you can see the injury severity score was 42. So the injury severity score is a scoring system that that has been developed to assess a person's injury severity. And it has been shown it correlates with mortality, especially in older people. Okay. So as you can see, the injury severity score is more than 9. So this is how uh, the the mortality will increase. So when I worked in a perioperative team while doing my OC's training, so we used to see all the patients of injury severity score more than 9. Okay, so 9 was the cutoff. So anyone who has more than 9, we used to see and provide geriatric care. So and So these are very good tips if you want to read about pediatric trauma services, how to develop them, and what are the standard guidelines. And now we see patients with polytrauma, neurotrauma, and complex chest injuries, complex limb injuries, and spine injuries as well. And most of these patients have the rib fractures, and we see a lot of patients who have falls and coming to the emergency department with rib fractures. And this is something which goes unnoticed sometimes, but could be the first presentation of osteoporosis, even though it's not an osteoporotic defining fracture. And unlike the younger population, the senior population has higher risk of mortality when they have hip fractures, and we need to have a standard care pathways of managing these rib fractures. Like whether these patients should be admitted under surgeons, admitted under geriatricians, and what type of teams who should be involved in management of these patients. This a standard protocol for patient fractures used in another setting. So we need to develop this kind of protocols here to our patient care. Right. Okay. So this is all about teamwork and surgeon, the geriatrician or a physician, anesthetist, physiotherapist, a nurse, and a dietitian, and maybe some other members needed for the patient's care during this perioperative period. Okay. And so this, I have come to the end of my presentation. So perioperative care in older people need a multidisciplinary approach. And we have three phases in perioperative care: pre-op phase, intra-op phase, and post-op phase. So there are certain things we have to do in all these three phases to get a better patient outcome. And multidisciplinary teamwork is quite important. Geriatrician or perioperative physician will be leading the team, as well as the other members of the multidisciplinary team, like physiotherapists, speech and language therapists, occupational therapists, nurses. Everybody has their role to play. Uh, Thank you very much. I'm happy to answer any questions if you have.
Thank you, Dr. Sitira. Thank you. I think we have a couple of questions appeared in the Q&A. I will read out the questions. So, first question is on yes, many patients in Sri Lanka opted for non-surgical management of the fractures. What are the main areas to manage in those patients?
Yeah. So I guess we are talking more about hip fracture. So if you there, there are certain other fractures also, like we manage non-operative, but I see a lot of patients with fractures. Sometimes they opt for none of management, and uh, the hip fractures, surgery is mainly considered also as a palliative procedure because for even for pain management, the best thing is to do the surgery. So the current standard is, unless patient they uh, have a high risk of dying during the surgery, on table death, unless we think patient is going to die during the procedure, we have to go ahead with surgery. So if someone is not undergoing surgery for certain under certain circumstances, still we need to manage their pain, and most of these patients will develop delirium. So manage their delirium, and still we need to gradually mobilize them at some point and treat the osteoporosis and try to manage falls. But usually, like none of patients will be drastically, their outcome will be uh, poorer compared to patients who undergo surgery. So, as physicians, we usually, try to get the patient ready as much as possible to get the surgery done. So that's the best thing for the patient in the most of the cases, right? And can patients wait their post-op? So the current standard is patient can wait their post-op day one, unless they have a contraindication, a medical contraindication. Like for example, I gave you earlier, if patient develop post-operative mitral infarction, if they develop pulmonary embolism, of course you can't. Otherwise, post-op day one, we have to mobilize after hip fracture surgery, and there are some surgical contraindications as well, as I told you before. If surgeon has put a long nail, and if they are not happy to mobilize on day one, uh, for the risk of dislodging or getting a refracture, we might sometimes delay. But most of the patients, current standard is to mobilize them day one after the surgery. If a geriatric patient comes with a traumatic neck or femur fracture, would you wait till day seven? No. So hip fracture, if, like is a if patient in case if patient is having high velocity injury like RTA, it might be a different case. But if this is a fragility fracture, if patient has fallen from standing height, or patient has very minor injury, you might consider as a fragility fracture. No need to do a DEXA scan. So we have to treat for uh, osteoporosis, and we can do a DEXA scan in 1 year time, just to see patient's baseline and whether patient has how bad is osteoporosis. But for treatment of osteoporosis, you don't have to do a DEXA scan after the hip.
Thank you, Dr. Sitira. And I have one question.
Yeah.
What is the place of perioperative sedative treatments like benzodiazepines in old
Okay.
adults?
Yeah. So sedatives usually we try to avoid perioperatively, uh, mainly because of the risk of delirium. And if someone is having agitated delirium, usually we try to use a small dose of antipsychotics. So usually the haloperidol is the drug usually we mainly use. If someone is having Parkinson's disease, we might sometimes go ahead with a sedative, but mostly a drug like quetiapine we can try. But other than that, we don't encourage sedatives. So I have seen some people use sedatives just because of the risk of getting and developing anxiety post-operative, but routine use of sedatives is not encouraged because of the risk of post-operative delirium.
Okay, thank you. And one other question, do we have a multidisciplinary team approach for orthogeriatric care at the moment?
Yeah, so at the moment, orthogeriatric care is a new concept in Sri Lanka. So most of the orthopedic surgeons they have their own physiotherapists. So they do come and they mobilize, but the involvement of the physician or a geriatrician is not very welcome at this point because we know like need to develop a lot of collaborations at the moment and. And there are a lot of aspects to be improved in nursing care as well as getting involved the other members of the multidisciplinary team. But most of the orthopedic surgeons they do have physiotherapists and they uh, come and see the patients post post-operatively in orthopedic wards.
Right. Thank you very much, Dr. Sitira. I think that brings to the end of this lecture. And thank you very much for your time and the comprehensive lecture that you delivered. I hope it was a very useful opportunity for all the participants to widen their thoughts and knowledge on the orthogeriatric and perioperative medical care. So, on behalf of the Sri Lanka College of Medicine, let me thank immensely Dr. Sitira Senaviratne for your time and delivering the lecture today. So I hope our participants found it very useful today. And thank you very much, Sitira. And it's time to wind up the webinar. So I wish you all a very good day. Thank you.